TopMedTalk.
This is TopMedTalk, the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. The EBPOM World Congress is taking place this year between the 7th and the 9th of July at the British Library in London. Check out ebpom.org now.
Hello and welcome to TopMedTalk from the World Congress of Anesthesiologists here in Marrakech in Morocco. It's the 19th Congress that the WFSA have held, and I think it's one of their best. 4,000 delegates, 150 different countries, a terrific program and wonderful things to do out there in Marrakech. Mike Grocott.
I think it's been really special, actually. The environment is great. It's lovely and warm, although apparently those who arrived early were a little bit cold, which I find hard to believe.
But it snowed on the Atlas Mountains and we have fabulous views of the Alps. It was wonderful.
But an excellent meeting. Really, really good atmosphere. I'm so pleased they brought it to Marrakech.
And they've also invited a terrific faculty, and we're lucky enough to have two of them here today, Hilary Grocott and Michelle Chu.
Thank you, Kate. It's Hilary Grocott. I'm the head and professor of anesthesiology at the University of British Columbia. I'm a cardiothoracic anesthesiologist, and I've been coming to these sorts of world congresses for more than 30 years. Wonderful to be here in Marrakech. And if I might just put a plug in, it's going to be really great to welcome the world and these 150 plus countries to Vancouver in 2028 for the World Congress, where we'll be hosting that. Of course, I have a personal bias, but my, best city in the world in Vancouver. So we'll welcome the world to Canada.
What month of the year will it be?
It's May the 7th to 11th. It's probably the most pristine part of the weather in British Columbia.
I was going to make a comment about that.
The rain has stopped, which is ever present in the winter months. And, come springtime, it's going to be wonderful to be in Vancouver.
Oh, we can't wait to be there.
It'll be at the Convention Center, which is, just epic. Congress Center on the waterfront. It'll be wonderful to be there with everybody.
You're going to be busy over the next couple of years, aren't you?
Things are ramping up. It's 2 years away, but the hard work is underway right now and has been actually for quite some time.
So put that in your calendar, everyone. And Michelle Chu, welcome.
Hello, Kate and Mike and Hilary. I'm so happy to be with you today, and it is a great day in Marrakech. This is only my second WCA, and what a great time I'm having. I think Morocco is such a lovely country. It's, the weather's beautiful, the sun's shining. It's a great congress. People are incredibly warm and hospitable, and I'm just having a great time. And I'm looking forward to coming to Vancouver next year, Hilary.
Great.
So born in Malaysia, schooling and training in Australia, and then moved to Sweden.
I moved to Denmark and then Sweden, yes.
Yeah, and what do you do there now?
So I'm a professor of anesthesia and intensive care at the Karolinska Institute.
Fantastic.
And we mustn't forget to plug the fact that we have a very special perioperative profile with Michelle. I think that Andy did a few weeks ago, so look out for that on TopMedTalk.
Yes, and you'll learn how many languages Michelle speaks.
Actually, probably not a single language very well.
You're way too modest. Why don't we start with you, because you're in a session about preparing patients for surgery and about assessing them in various ways and monitoring. Can you tell us a bit about your talk?
Absolutely. So I was really privileged to have this session with Mike Grocott and Thomas Sharon, two real leaders in hemodynamic management and perioperative cardiac assessment. Because there's so much confusion around it, isn't it? We know that cardiovascular risk factors are very common amongst patients undergoing non-cardiac surgery. We do know that cardiac complications are the third most common complications in patients undergoing non-cardiac surgery. We assess our patients really only using the SAPS score. There are other risk scores around, but they are not very sensitive and not very specific. So a lot of the preoperative assessment conversation has concentrated on how we can improve those assessments. And if we can improve those assessments, can we do anything about it? My talk was about cardiac biomarkers, both preoperatively and intraoperatively. There is an incredible amount of data out there, but nothing really that tells us that in an individual patient, we can use cardiac biomarkers to discriminate a patient that will have or will not have disease. There are a huge number of prognostic studies. They will tell us about populations at risk, whether or not you intervene. And there is almost no study on a biomarker-led management.
You were there, Mike, at the talk because you were also in the session.
It was a great talk.
Yeah. What sort of controversies arose from Michelle's presentation about biomarkers?
There was a lot of chit-chat afterwards about troponins, and so we measure them, then what do we do about them, what are the implications clinically and in terms of subsequent management. I mean, forgive me, but I'm not sure I got a clear message at the end of it. Not your talk was fantastic, but it's pretty clear that people in different environments and contexts are acting in completely different ways. And it's not entirely clear to me it makes that much difference at the moment in the absence of a clearly defined pathway to follow up a positive test. Did I get the right message?
You'd absolutely got the right message, and it is unclear. It's very much up to you as a physician, what your patients would like, and what your healthcare system is willing to invest. That whole risk-benefit assessment thing. If you're risk-averse, by all means do it, but then you need to have a really good plan on how to follow up patients when your biomarkers are positive. And remember, of course, biomarkers is just one little piece of the puzzle. It's a great marker for badness, but the kinds of badness may not be what you think. It's not always cardiac. It could be acute renal injury. It could be pulmonary embolism or sepsis. And by that, I mean, increased cardiac troponins. So I think it's very much up to the values, the preferences, the risk-benefit considerations that you as a physician, your patient, and your healthcare system will consider. And that will be different from institution to institution.
Michelle, maybe I could jump in there for a moment. Would you say, I mean, it's a moving field. As much of science, continues to evolve, we have to be prepared to go where the data points us, but also be comfortable with the uncertainty of what these biomarkers perhaps mean, but also the uncertainty of what to do with them afterwards. And I think that's where people struggle sometimes without that definitive, data pointing us in the correct direction. Sometimes they throw up their hands and say, I don't know what to do with it, so I'll do nothing.
Yeah.
But I always think it's also a call to do more science to better understand
Indeed.
what these things mean.
And so well said. One of the biggest mistakes that we make is just give up because the data is not clear. So this is really a call to do more science. And at our institution, we decide that we have to use the data to improve outcomes for our patients. We don't know if it will, but we will test it. We will test it in a limited number of patients, in those at very, very high risk that probably have the biggest chance to benefit from preoperative echocardiography, perioperative cardiac biomarker screening, and we will learn as the process goes on. One of the biggest fallacies about cardiac biomarkers is that, number one, they're too expensive. They are expensive if we implement this on a routine screening basis. So you really need to pick out your patients. And it is also a fallacy that you can't do anything about it, because we know that increased troponins can represent a host of complications: acute kidney injury, pulmonary embolism, sepsis, acute myocardial injury, heart failure. They are also very important complications that can be flagged by increased cardiac troponins, and they have very clear management pathways. So it's not completely true that we don't know how to manage acute myocardial injury. It depends on the cause of acute myocardial injury.
So to sort of make a bridge to Hilary's talk, I wondered if we could talk a bit about NT-proBNP and other things that are used to look for sort of, I believe, more severe cardiac issues or heart failure. What did you say in your presentation about that?
I really like NT-proBNP. We've had some very nice studies to show that NT-proBNP in many ways is more valuable than perioperative cardiac troponins. It's incredibly specific for heart failure, both as a preoperative biomarker, but as well as a postoperative biomarker. Now, acute heart failure is not as benign as it sounds.
Doesn't sound very benign to me.
Well, our doctors we're most worried about aortic stenosis and acute myocardial infarction. But the Basel PMI study showed very clearly amongst patients with acute myocardial injury, if you could etiology stratify them, so the majority of patients had non-cardiac causes, but amongst the patients that had cardiac causes, heart failure occurred in 2.5% of the population, but it was the most lethal complication. So preoperative NT-proBNP definitely prognostically significant. Many studies showing this. Not very many studies showing the value of post-operative NT-proBNP. I know it's also recommended by the Canadian guidelines. So the Canadians guessed correctly in 2017. They were way before anybody else.
And it wasn't easy to do at the time. There was considerable uncertainty, but at some point, in pulling into what you said earlier on, you have to make a commitment to start doing this and then study it. And sometimes these things pan out and they're helpful clinically, and sometimes they're not. But that was definitely a decision that was made, and it wasn't an easy one. But it has, as you said, turned out to be very useful. And we use it routinely to screen patients for underlying cardiovascular conditions, including heart failure.
So Hilary, as someone who doesn't have that available routinely in my clinical practice, can you give us a flavour of what you're finding and what you're doing in response to finding it? So, how's it changing practice overall?
Well, I think in terms of changing practice overall, I think that when patients come for surgery, either cardiovascular surgery or non-cardiovascular surgery, they come with a number of clinical conditions. And sometimes these things, you see them on paper, they've got atrial fibrillation, they had a past history of heart failure, but you don't know how current or relevant those things are to their history. But if you have somebody with atrial fibrillation and it's managed and their NT-proBNP is low, to me, that tells me, sure, they've got atrial fibrillation, but it's under control. But there's also that patient who has atrial fibrillation in their medical record and they're not well managed. And I think these tests such as NT-proBNP can sort of, highlight that this is a patient that is at risk. Even though they say they have the same history on paper as the next patient, this is the one that you have to spend a little bit more time. And perhaps as the perioperative physicians that we are, institute some of the other, medical consultations, get the cardiologists involved again, get the internal medicine, people involved again, and understand how we can better optimize these patients.
So, Hilary, when we as anaesthetists, in particular non-cardiac anaesthetists, are with our patients, my understanding is we have to have a fairly high index of suspicion about right heart failure because sometimes it's not obvious from the patient's medical record or past history. So what do you advocate for us to ask our patients in terms of history or investigations that they've had so that we can not miss anyone with substantial right heart failure?
Yeah, well, thank you, Kate. And you did point out that one of the lectures that I gave at this World Congress was on optimizing the failing right ventricle, and right ventricular failure and pulmonary hypertension is one of the real red flags to me in the perioperative space. Those patients are at high risk of decompensating. But you're right, detecting some of those problems, can be a problem, but it goes back to the basics of medicine in terms of the history and the physical examination and some of the investigations that we can do. And we do know there's some patients that are high risk, patients with known thromboembolic disease, patients with bad pulmonary history and smoking and emphysema and these sorts of complications where we know that they can have a higher risk of compromise in their right ventricle and high pulmonary artery pressures. But the physical examination is very important. Do they have overt signs of right heart failure in terms of peripheral edema, elevated jugular venous pressure on physical examination? You're looking at the tests that they've had. Some of these patients had the luxury of having some echocardiographic analysis, and you can see the overt RV failure on there, the dilated hypocontractile right ventricle. But pulling it back to the biomarkers, somebody who has that sort of history and has an elevated proBNP, that they're in that process of having heart failure. And that's a red flag to me. And probably to me, pulmonary hypertension and the failing right ventricle is, after being involved in cardiovascular anesthesia for more than 3 decades, and it's the only clinical condition that I have the utmost of respect for. And those patients are at high risk of postoperative not just postoperative complications, but complications immediately in the operating room. I can tell you the vast majority of patients come through surgery without any problems in the intraoperative period. The problems happen postoperatively. Failing right ventricle with pulmonary hypertension, that's where you see compromise in the operating room. And it's the only, one of the few times in my career where you go from induction of anesthesia to CPR on these patients if you don't respect this condition. And
that's happened to me, and my co-hosts are nodding. Yeah. So there's a whole piece about talking to these patients and their families and advanced care directives and shared decision making. But let's cut to the chase of, you've got a patient who everyone's decided or someone's decided that they've got to have an operation, and you're going to induce them. What are the keys to optimizing their right ventricle during the induction process.
Yeah, preparation. You can't react to it. You have to preemptively address these issues. Sometimes they're coming for arguably relatively, lower risk procedures, but they're a high risk patient. If I have somebody who with known pulmonary hypertension and right ventricular failure, you don't have time to mix up a bag of epinephrine or a syringe of norepinephrine and these sorts of things, unless it's already in line and infusing when you're putting these patients to sleep, you are going to quickly, lose those patients. So preoperative preparation and having all the barrels loaded, if you will, so that you're ready to immediately intervene.
And monitoring, what do you look for?
It depends on the clinical situation. I mean, apart from the usual standard monitors, again, you want to have beat-to-beat ability to monitor their blood pressure to detect that early hypotension. So intra-arterial catheters, to me, are really critical. You cannot wait, for an oscillometric blood pressure cuff to then not give a reading and then you repeat it and realize that you've lost 20, 30, 60 seconds of hypotension. You need to treat that hypotension within seconds of its onset. So to me, intra-arterial blood pressure monitoring is critical in these patients. For the vast majority of the patients, I think that's one of the critical pieces. Other invasive monitoring, it depends on the procedure that they're going for. And I still think that there's a role in certain cases for pulmonary arterial pressure monitoring as well to detect the acutely decompensating right ventricle.
And would you do that with a PA catheter or an echo?
Depends on the case. If somebody's undergoing endotracheal intubation and you have the access to transesophageal echocardiographic monitoring, I think that's a reasonable thing to do, but that's high fidelity, expensive equipment that's not widely available. Similarly, pulmonary artery catheters are not available. They're not a panacea. They're not a therapeutic. They can help you with some of those decisions, but I think that once you understand that you have a high-risk patient, I think that you could still institute therapy without some of those things. And arguably, there's probably some patients that you institute therapy on that may not have needed it. But if you miss that one patient and don't have those cardiovascular drugs in line and running, you can really lose them.
So you've got an IV. Before you start, how should you optimize their fluid status?
The failing right ventricle, I think, is unique. I think when you look at cardiovascular physiology and we talk about these things such as Starling curves and the understanding pressure volume relationships, I think there's still a role for some modest fluid loading.
Right.
Modest. What does that mean? 250 mils of a balanced salt solution, I think is still reasonable. So I'll always give a little bit of fluid. But the thing with the right ventricle is too much fluid, you can really tip them over into worsening heart failure. So there's always a little bit of fluid that goes in.
How can you tell if you've given enough?
Yeah, sometimes you don't know right away. And so I think it's one of those things where 250 mils of balanced salt solution, it's unlikely that you're going to give them too much. But I would rather err on the side of giving them, not enough than giving them too much in those sorts of situations.
So you've got an IV, an Artline, or maybe a non-invasive beat-to-beat monitor, and you've given them a fluid bolus, and you're running a vasopressor, either norepinephrine or whatever, phenylephrine or whatever. What drugs have you got in the quiver to rescue the patient who is clearly, these 120, 90, 80... 60.
Yeah.
Oh my God.
So when I induce anesthesia on those patients, I have an infusion of, typically I choose norepinephrine and running it peripherally, which can be done safely in a well-functioning IV. Generally, we'll have that running in the background. But in addition to that, I will usually have some epinephrine also running in a low dose in the background. Low dose epinephrine does not cause tachycardia. It does not cause overt hypertension, does not cause overt cardiac irritability at low doses. By low doses, in the 0.03 to 0.05 mics per kilo per minute range. I have that running in the background.
As an inotrope.
As an inotrope to support that failing right ventricle. And if they start to decompensate, I can quickly ramp up those therapies. But there's not enough time to not have it ready, have it prepared, even if it's prepared to put it in the line and start running, you've lost that one already.
My colleagues seem to like calcium.
Yeah.
What do you think about that?
I think calcium is a could use it as
Michelle's shrugging her shoulders about calcium.
Yeah, I personally don't use. I think there's some physiologic reasons why we could use calcium. Calcium, is a great vasopressor acutely, causing peripheral arterial vasoconstriction. Calcium is intracellularly is how these inotropes work by increasing intracellular calcium. So I think it can probably get you out of a jam when you're trying to rescue this patient. A gram of calcium is probably beneficial. I don't think it's going to be harmful. But relying on it solely, firstly, I think that these patients, they can acutely decompensate, but I think you need to have some maintenance therapies going on as well. And that's why I like continuous infusions of these catechol. The one thing that I don't like in the patient that was coming for cardiovascular surgery, I think phosphodiesterase inhibitors such as milrinone are great drugs. I don't think they're great rescue drugs. Because of the unpredictability of the hypotension that you can get as well. To me, one of the critical messages in managing the RV is maintaining systolic arterial blood pressure, so that you don't run into right ventricular ischemia and that downward spiral of further cardiovascular compromise.
Yeah.
I couldn't agree more. I think the right ventricle is absolutely fascinating. And once it starts to fail, you're in trouble.
Yeah.
I also believe that the key to managing these patients is get them as optimized as possible preoperatively. And of course, the moment you induce positive pressure ventilation, everything changes, because that small increase in intrathoracic pressure makes all the difference to pulmonary vascular resistance. This is, in the few patients, and I'm glad it's only been a few patients that have totally crashed after induction. That's usually the mechanism. And then on top of that is the relative ischemia of the right ventricle because your systolic blood pressure has decreased. So in our practice, and we do have a few patients undergoing non-cardiac surgery with, significant pulmonary hypertension, we also run a background infusion of noradrenaline, and then we have the adrenaline drawn up ready to run as an infusion. So perhaps we should do that. We should start the adrenaline pre-induction as well, Hilary.
Yeah, no, I think it's honestly, I use it a lot and I see little downside, to starting these lower doses that can be quickly ramped up. But I want to go back to something you brought up about ventilation. And I think that's often underappreciated, just how important optimizing the respiratory mechanics are in these patients. And we know that there's this relationship, sort of a U-shaped curve, if you will, between pulmonary vascular resistance and intrathoracic volumes. And then trying to prevent overdistension, which increases PVR, and trying to prevent the compression of sort of extra alveolar vessels by draining pleural effusions, avoiding atelectasis, and really trying to maintain that ventilatory strategy to optimize that functional residual capacity where the pulmonary vascular resistance is lowest. That's really critical. Oftentimes you see patients and they come right heart failure and they've got these large pleural effusions, and people just sometimes overlook the fact at how important that mechanical impact of those pleural effusions are adversely on pulmonary vascular resistance. Draining those preoperatively sometimes is actually warranted.
It's the small things that will make a difference. And I want to come back to your comment about monitoring. It's quite often a fallacy that the pulmonary artery catheter is better or worse than echocardiography plus other techniques. I guess it depends on what information you're after. The pulmonary artery catheter is fantastic for direct measurement of intracardiac pressures. Echocardiography won't do that for you. It'll estimate pressures for you. However, if you're looking for an acute dilation of the right ventricle, echo is the only way to do this because the pressures will tend to lag, won't they? Pressures will rise in the right side, will rise later after the dilatation occurs. So if you want to see that immediate dilation after your 250 mils of fluid bolus, probably echo is the quickest way of detecting that. The other thing that we have started doing now as well is not to give the fluids because we don't want too many people in West Zone 3. We know that fluids do increase the proportion of West Zone 3 compared to 1 and 2. We've started doing the in-expiratory occlusion tests quite a lot just to see whether or not the RV dilates up to that maneuver.
Interesting. Yeah, I don't have any experience with that myself.
I wonder if I could ask you both. The patient with the failing right heart, very difficult to manage. We've got a whole set of different interventions, so fluids, inotropes, pressors, plus, as you've touched on, the management of the ventilation to deal with afterload. What is our target? So I guess my explicit question is, we kind of wrestle with cardiac output monitoring and flow oxygen delivery as being a key target in general, but is this a specific case where actually that might be what we're looking for?
Yeah, I think there's probably some value in select patients, but using those advanced monitoring, on a more broader group of patients, I think is a bit of a challenge because you don't always have access to those. But I think cardiac output monitoring is valuable, 100%. I think that you can really understand whether some of these therapeutics are having a benefit. One of the things I actually find useful in the really tenuous patient where there's uncertainty, I actually am a big advocate for tissue oximetry. It's a slightly more expensive technology, but I'll often put a cerebral oximeter on these patients, not bilateral. I don't think I need to know the symmetry of blood flow across the brain, but I'll often, in these patients, put on a single cerebral oximetry probe. And I find that is oftentimes an early warning sign when things are starting to fall apart. Or alternatively, when you have a little bit of hypotension and you're intervening, but the cerebral oximetry is steady, I can kind of rest easy for a moment and say, okay, I've got some breathing space here. We got a little bit of hypotension, but we're still okay. But when that cerebral oximetry starts going down on those patients, you have got to get on that immediately. The signal response time, if you will, is seconds. If you start compromising your cardiac output to the point that you're seeing a decrease in your cerebral oximetry, you've got to start getting even more aggressive. So I do that, and I balance the cost issue because it's not a cheap technology, but I balance that cost by just putting one sensor on, and the brain is what I typically do. Although I know that others also look at somatic, sensing as well.
Interesting. Thank you.
Well, what a fascinating podcast. I'm going to have to go home and look up a few of the things that have been mentioned. I was just thinking what the main message is, and it's careful planning and vigilance and action, isn't it? It's not a thing you can just rush into without thinking about, because that won't benefit the patients at all.
Preparation is key.
Preparation
and
is
just
key.
rely on reaction.
Yeah. So thank you, Mike, for joining me on the podcast. You can find this podcast on our website. You can also find it through any podcatcher. We're on social media. We're on Facebook. We're on LinkedIn. We're on X. We're on Blue Sky. If you go there, please give us a big thumbs up, because that helps us get our podcast out free and open access to the world. We'd like to thank our sponsors, and they are GE and BD Advanced Patient Monitoring. We'd also like to thank the WFSA for their generous hospitality at this wonderful meeting.
TopMedTalk.
TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. Join clinicians from around the world at EBPOM World Congress 2026 between the 7th and the 9th of July at the British Library in London. 3 days of evidence-based perioperative medicine, global insights and expert debate, featuring speakers including Michael Marmot and Ken Rockwood. Go now to edpom.org. That's edpom.org.